Welcome, everyone. I see people are coming into the room now. Welcome to Lighthouse Lab Services webinar on screening and surveillance testing for COVID-19. We're going to give some different ideas on what steps you may need to take and hopefully clarify what the differences are in those different types of testing. So we appreciate you joining us today. We do have Ann Lambrix from Vachette on the line as well, who's going to cover some of the billing, coding, revenue cycle management aspects of this testing as part of the presentation as well. So we'll be co-presenting. As we get started here, just some general housekeeping. We're going to keep everybody's microphones muted. However, we do encourage you to ask questions, and so you can do that through either the Q&A or the chat feature. You'll find that on the right side of your screen. We also are going to run some polls during this webinar because we want to hear from you guys too. And so as you see those polls come up, you can go ahead and respond and give your information or your thoughts regarding those. And we look forward to hearing what you have to say, and hopefully that'll be helpful for you to hear what your peers are seeing as well. There's a handout section, and we have dropped in a PDF, or will be dropping in a PDF with some of the information that supplements what we're going to be talking about today, if that's helpful. And yeah, so we're going to go ahead and get started. So Lighthouse Lab Services, just a little bit about us before we jump into it. We are a laboratory management consulting, recruiting, staffing firm. So we run some of the largest communities of medical laboratory scientists on Facebook and LinkedIn in the world, and we encourage you to join those if you're not already part of them. We like to hear what's going on and try to view ourselves as kind of a forum for people to come together and exchange ideas. We also are the largest medical laboratory-specific recruiting and staffing firm in the country, so if you're having a hard time finding molecular scientists, if you need a medical lab director, we supply medical lab directors to over 225 labs around the country, whether you need that part-time or full-time. And then consulting. So if you want to add a line of testing, you need to set up a new lab, you need help with a CLIA application or Medicare application or out-of-state application to receive samples from other states, that's what we do, and we would love to help. Or just to come in and do an audit of what you have there, whether it's in the lab or your revenue cycle management department. We'd love to give some advice on best practice and ways that you might be able to see some more margin through some improvements that can be made. So reach out to us if there's ever anything we can do to help. We do keep these webinars free, and we intend to keep it that way, but we do this as part of the services we provide. So today we're going to talk about something that you're probably hearing about and maybe hearing too much about, but there is some lack of clarity from the people I'm speaking with on what is the difference between the different surveillance, screening, diagnostic testing, exactly what is it that makes those three different types of testing different, and where's the market headed, right? So we've seen some really strong COVID testing historically. We're starting to see that drop off a bit. It looks like 84% of the people polled here have seen a considerable decrease in the amount of COVID testing. So what's next? According to the New York Times, and I pulled this stat a couple days ago, about 142 million people have at least received one of the vaccine shots. So we certainly see a very strong trend. That's about half the country of adults, more than half, that have started getting the vaccine, and that's going to create some exponential decay in COVID testing diagnostic volume. And so, as we saw it ramp up exponentially, I think we're going to see it decrease exponentially as well, where you might see halving happen, every day or two, where we might see it fall really dramatically. I think peak was end of January, maybe early February. I have a graph there on the right that you can look at where you can see COVID testing volume compared to regular testing volume. You will see that regular testing volume is on an upward trend line, so that's good, but COVID testing volume is certainly on the downslope. We do think that there's going to be a continued need for diagnostic testing. Children have not been vaccinated under 16. Doesn't look like that's going to happen real soon. I think it will happen later this year, but there's going to be testing that needs to happen for them. Anywhere that we see those unvaccinated groups gathering, it would make sense for testing to continue. And then we also see a need for testing in order to monitor for outbreaks, especially if there's a mutation that jumps the vaccine. So there's going to continue to be testing, we also are hearing that herd immunity might not be reachable. So it's going to be part of our future, but I think it'll be a much smaller portion of overall testing than it has been historically. And I don't think that's news to anybody on the call. But we do think that as a result of that, there's going to be a pivot from diagnostic into surveillance screening. So we're going to jump into kind of what does that mean? So surveillance testing, surveillance is ongoing and it's systematic in nature. It's used to monitor for an occurrence in a population. So surveillance testing is not at the individual level, it's at the population level. So that's the key distinguisher for surveillance testing. Could be done on a random sampling of people, could be done on everybody in that population. It's not regulated by the FDA. Physician orders typically not needed. Check your state regs on that, but typically not needed, at least from a federal standpoint. PHI is not collected, or at least is not visible or seen at the laboratory. So that's something that's a little bit different. And surprisingly, maybe to some of you, surveillance testing does not require a CLIA certificate, right? Because it's not a diagnostic test. It does not fall under that. I think it's still going to be performed in CLIA environments. Everyone I've seen doing this so far has been a CLIA lab, but not required for surveillance, which is a little bit surprising, I think, to some. So screening testing is kind of in between on the spectrum of surveillance testing and traditional diagnostic testing, and it is at the individual level. And I think the key takeaway on screening is that it's for asymptomatic people, really. So this is not testing where someone goes into their physician and says, I lost my sense of smell, that you would use. This is typically used without any symptoms, just to monitor people coming back to work, going to school. Surveillance can also be used for that, and we'll talk about that a little bit more. Screening testing is regulated by the FDA. It does fall in the CLIA environment. Physician order is needed if required in your state. PHI is typically collected. All HIPAA rules are need to be followed. So looks a lot more like traditional diagnostic testing, except it's just targeting asymptomatic people, and it's typically done through pooling. I think you guys all probably know what pooling is at this point. Both the surveillance and screening models that we see out there that are dominant are using pooling. So by definition, you don't have to pool to do screening or surveillance, but I haven't seen anybody really doing that without pooling being part of that. And so sample pooling, I think you guys know what that is, but gives you the opportunity to save on equipment costs. Throughput is a lot higher by doing pooling. You save on reagents, you save on collection supplies, potentially, depending on where the pool is occurring. There's different models out there. Some people are pooling out at the point of collection, so that it might own the whole pool of candidates. If you did a whole classroom, might be in one collection device that's sent back to the lab, so it's saved there. Sometimes that pooling is occurring once those collected samples get to the laboratory. It's normally done prior to extraction. There is some digital pooling that can happen as well. The cost savings is pretty dramatic though, right? If you can think of maybe putting 10, 15, even up to 24 different patients in one well versus one patient, you can imagine the throughput return for that and how that would affect costs. So it's very dramatic. I think it's what we need. I think it is going to be the dominant strategy for testing as the kids start going back to school. We do see, that's the direction that the market is headed. And I don't think without some kind of pooling and pivot into screening and surveillance, that a traditional diagnostic testing lab is going to be able to compete, right? The cost per test is just a world away. So some of the economics on that, surveillance testing via pooling brings the cost down in the $5 to $10 per sample range. That's for the lab. We typically see labs charging a cash pay rate of in the 10 to 20 range. So pretty dramatically different than what we've seen out there as market rates historically. We've been seeing a compression and a trend towards this pricing for a little bit now. And there are some labs I know that are using really high automation that are getting down to that $10 price point through traditional diagnostic testing, which is really impressive. But for the most part, I think everybody's been north of that number. And got a poll going for you guys. Reflexing to positive. So I want to explain kind of the different surveillance testing models that are out there, and what to think about as you're trying to determine which way you want to take your laboratory if you're going to go that route. So in order to reflex a positive, you'll need to collect the samples individually, right? So one model that's out there is to collect samples. That we'll use a school classroom as the example, have everybody in the class provide a sample, maybe it's swab, maybe it's saliva. I'm seeing both of those out there in the marketplace, and put that all into one collection device. By doing that, we've completely lost the ability to identify at the individual level, which is fine. So it does keep costs down. Like we said, you only have one collection supply too. And it comes back to the lab and they would test the whole class as either positive or negative, right? So Mrs. Brown's class, they all go around, swab, put it into a collection device, comes back to the lab, and is processed as one sample. If it pops positive, everybody there is going to be a positive. So the logic behind that is the effect on that classroom is pretty much the same, regardless of knowing who in the class was positive. You could say, everybody was exposed. So no matter if it was Johnny or Billy, then everybody needs to stay home and quarantine, or they could all go seek out their own individual diagnostic testing. At that point, some groups are using rapid testing to test the people in the pool that tested positive. I feel like that's not going to work out in the school environment, just because the PCR results typically going to come back later that night or the next day. So getting the students back to school would be challenging and probably a bad idea if we know that at least one of them is positive and they've all been exposed. But you could maybe send kits to the home. You're going to need to make sure that those kits are approved for home collection if you do it that route, or maybe you push them to do their own testing. So that's one way of doing it. It is able to reduce the cost dramatically. I've seen pricing as low as $7 per sample using that pooling, where the pooling happens at the collection site. The other way to do it would be to collect individual samples, maybe even collect some PHI out in the field, some basic information, name, first name, last name, something along those lines, and then attaching a unique identifier barcode number to that, and then passing to the laboratory, no PHI, just putting those barcoded numbers through and into a pool so you know who's in which pool. You'll have to use a technology provider or maybe a third-party provider that collects some of that information, passes to the laboratory, only barcoded information, no PHI, but allows, by doing that, you allow groups to, when they have a positive pool, to go back to the third-party provider or the technology to inquire or query for the information to run a diagnostic test on everybody that's in the group, and you're then able to run that without a recollection. So that's the big benefit of that. You do have the increased cost of the collection supplies for each individual. You do have to have some kind of partner or technology in the mix to act as sort of a liaison between the patient and the lab, so that passing of PHI is handled. But I do think that is probably the best plan. Not having to recollect is a really important problem to solve. And so that's the only one I've seen that does that. And I think you're able to get that price point, like I said, under $10, and then you could mark it up and probably be anywhere up to $20 at market rate. And I think you'll still see good interest in the product. I'm going to also just show a quick video on this. It's basically what I've explained. This is a video we put together that explains pooling, surveillance testing. If you guys were interested and you wanted our assistance with putting together a bid for a government proposal, we've done that for a few different labs. We're happy to help with that, and we're also able to create a similar video or marketing piece for you with your lab and your information that explains these concepts in a way that's easy to understand for even somebody that's not in a lab environment, maybe a principal or school teacher, but I'll run that real quick.
Surveillance testing is a form of infectious disease testing used by institutions and organizations to monitor and characterize potential outbreaks in their communities. It is used to gather information about large groups rather than at the individual level, and can help organizations like workplaces, colleges, or schools. The results of these surveillance tests can be used to make important decisions that keep people safe, like whether to open schools, maintain social distancing, or employ other mitigation measures. One way COVID-19 surveillance testing can be conducted is by collecting specimens from multiple people and testing them together in groups called pools. With pooled testing, one test is performed on a whole group of samples, eliminating the need to run each individual sample on its own. In this example, we are using a saliva-based test to perform pooled testing. If the test comes back negative, the organization will know the whole group is negative. If the test comes back positive, the organization will know there is a risk of possible infection, and the group may need individual diagnostic testing. This saves time and money by reducing the number of tests being run and lets organizations get back to work or school. While there are other ways to conduct surveillance testing, saliva-based testing is an easy and minimally invasive way to collect specimens from large groups for the purposes of pooled testing. It also doesn't require specialized training. Just spit in the tube and send it away. As communities across the country look for ways to get back to normal, surveillance testing is a way that laboratories can help. If your laboratory is interested in exploring how surveillance testing could help you to serve your community, call Lighthouse Lab Services today.
All right, so that is just a simplified version and something we put together, something that we're happy to share with you. If you're interested in working with us to put together a program or a bid, let us know. We can certainly help. The other part I wanted to get into was some of this government funding, right? So you probably heard quite a bit about this. I just pulled some of the bigger numbers on some of the funding that's out there. American Rescue Plan under President Biden has put a $1.75 billion plan together to expand testing. They also have put a focus in there on sequencing for the variant. So that first one that went out kind of was worded in a way that they really seem to want to make sure that they're able to track the different variants. On March 17th, there was an updated announcement, and the HHS plans to invest $12 billion to expand COVID testing nationwide with a focus on schools and promote equity, meaning people that don't have access to testing, homeless shelters and things are part of that plan. And then we also saw that CARES Act, the HEERF, Higher Education Emergency Relief Fund, which had $2.2 trillion. That was very broad. That was for impact on the economy from COVID and trying to deal with that. But of that, $14 billion was given to the Office of Post-Secondary Education, and we think that a lot of that's going to flow through towards school testing in particular. So you may have heard of these hub proposals. We've put in to be the hub proposal, the hub coordinator in the South region, and we're a partner on proposals in all of the other three regions, Northeast, Midwest, and West as well at Lighthouse. And we do think that that's going to be a big part of how this testing is rolled out. I think there's about 155 applicants for that, and they've narrowed it down to a list of, I believe it's 22. We're hoping to receive notification within the next 10 days or so on who's been selected for those coordinators in the different regions. We plan to use a network of laboratories to deliver that service, and you may have seen our registration links to collect information on labs that are interested, and if you filled that out, we appreciate it. I know we've gotten a lot of questions on, what's the verdict? Did they choose someone yet? They have not. In traditional government fashion, they've delayed and made this a pushed out deadline. And so we're hearing mid-May now as when we think that determination is going to occur. We also are seeing a change, though, where some of the states and schools are doing things on their own and have decided to just put together their own plans, have put their own RFPs out. We've helped two different states with laboratories in two different states to craft an RFP and put that together. If that's something you'd like us to help you do, we would love to do that. And it can be all in your name and your information. We'd just love to work with you on validating for pooling and surveillance, if that's something that you're interested in, and giving you the marketing collateral to be able to execute on that as well. So that said, I would love to turn this over to Ann Lambrix, who focuses on the RCM piece and is going to go over a little bit of the billing side of this. That's going to be an important part. Things have been happening really quickly with COVID. We do hear chatter that the government has formed some task force to go ahead and audit some of the COVID testing labs out there. We expect that's going to be happening over the next year or two. Not sure if you've heard, but Lighthouse acquired Vachette Pathology last month hopefully it's about the right time frame. And we're really happy to have them on board and to bring their knowledge in the RCM space forward, and their ability to audit labs is probably what they do best. And so if you guys are interested in that at all and want to get ahead of it and have someone look through your books and how you've been paid for the COVID testing that you've done and how you structured yourself, reach out to us, let us know, and Ann and her team can really dig into that and just make sure that you're buttoned up and can sleep at night. But I'm going to go ahead and turn it over to Ann, and Ann's going to walk us through some of the things you need to know about the billing.
Yep. Thanks, Jon. As Jon indicated, there's just as far as with the revenue cycle and the billing for COVID, I always joke around, it's just been a wild ride, and trying to certainly stay on top of the new rules, regulations, the different clarifications that CMS puts out in regards to testing and again, billing for testing, the requirements by, your insurance payers, what they are required to pay for through the CARES Act versus what they're not required to pay for. Again, it's been a challenge, I would say an exciting challenge, but certainly a challenge nonetheless to make sure that we're understanding, again, the appropriate ways to bill for COVID testing. So we now have surveillance testing, again, as Jon indicated, being more of a forefront, or what we would indicate or what we would see is going to be the primarily focus for a lot of our labs. As far as billing for surveillance testing, again, there's been some clarification from CMS through the CARES Act. The clarification that was made the end of February from President Biden, again, came out and said simply, if you want a COVID test, the insurance company should pay for a COVID test. When looking at the actual clarification through the CARES Act, it does indicate, though, that the insurance payers are not required to reimburse for surveillance testing, or what they would say workplace screening. So again, what I'm advising clients is this still needs to be, again, as Jon indicated, this is not a diagnostic test. Therefore, it is not, should not be billed to the payer, insurance payer. It would be set up to client bill. So making an arrangement with the school or the workplace that you are setting up surveillance testing in order to, again, charge them back for those tests. Next slide. And again, just overall, the things that we talk about with our clients as far as establishing these relationships and the arrangements for surveillance testing. I always advise that if you're setting up contracts, especially when there's going to be, again, the exchange of monies for testing, really needs to have legal counsel and making sure that your contracts not only are compliant, but your contracts also protect you as the lab. One of the challenges is, again, for a lot of laboratories that I speak with, is you have certain you have groups that come to you and want to perform testing. They want you to bill, they may indicate they want you to bill the insurance companies. You may go back with guidance from CMS, guidance from the federal government. They want you to attempt to try to bill the insurance. And if you decide to do that, that is, again, a policy that I would say it's up to you if you decide that you want to attempt to bill insurance. Certainly, you are not prohibited from doing so. However, keep in mind, your contract should support or protect you in case the insurance company denies, which, again, they are not required to reimburse for surveillance testing. So if they end up denying the claim, how will you get paid? And that's what I think a lot of labs that I work with certainly, they're not protecting themselves in a contractual relationship with the ordering group. And so they're left holding the bag. They've performed the test. They've, in good faith, done the work, and they're not able to get paid. So certainly make sure that you are working with legal to make sure that the language in the contracts protect you in case there's no payment from an insurance company. Obviously, avoid pass-through billing arrangements. Consider, again, this gets into the legal counsel. So these are things that I would certainly advise sitting down with a healthcare attorney and making sure that your contracts are not in violation of any sort of statute or law, that you may in the future be at risk of a violation. And again, as I mentioned, I wouldn't agree to bill any insurance plans unless you have something in writing that if there's a denial, then you can client bill back for the testing. As Jon indicated, we do expect that there will be audits, and so when it comes to surveillance testing, because there is no diagnosis code that would support the medical necessity, I do expect that even if you do get paid, if you decide to bill an insurance company and you do get paid for surveillance testing, the payer may come back and audit, and so you would need to have supporting documentation to support the medical necessity of the test. That is where we feel that again, our labs will be at risk of having that money taken back. So again, just be prepared, and again, doing your due diligence of completing audits and making sure that what you're billing, is limiting your risk. It certainly will help protect you in the future.
Thanks, Ann. That's
Yep.
Jon, we can't hear you if you're speaking.
I can just kind of, I know, Jon, I don't know, we can't hear you. We certainly, here at Vachette, just talking more about audits. And again, what we're seeing, with testing, with COVID testing, and again, getting into surveillance testing, again, I anticipate that, there will be most likely further clarification, further guidance from payers, but in getting into billing insurance companies for surveillance testing, if you decide to move forward with submitting claims to an insurance company or to HRSA, please keep in mind, again, there may be payments. So just because you're getting paid doesn't mean that down the road the payer isn't going to look and say, wait a minute, we shouldn't have paid this. They'll complete audits. And again, potentially you will be at risk of takebacks. So what we try to do is again, think about these things proactively instead of being reactive 1-2 years down the road when a payer comes in and wants, hundreds of thousands of dollars back because they determine that they are not responsible for paying for surveillance testing. So that's just the kind of discussions that we have with our clients, and just again making sure we're working through the process and setting our clients up for success, hopefully down the road, to not only get paid but to protect what they have been paid.
Thank you, Ann. Hopefully you guys can hear me now. Sorry about that. I had a technical glitch, I guess, but I've switched. Yes, very well said. Let us know if we can help. I do think we have a few questions that have come through. A lot of those are around sensitivity. If you want to reach out to us directly, I can connect you to our scientific team. The sensitivity is going to depend on the pool size, right? Obviously, the larger pool size you go, the more you'll see an impact on sensitivity, but we are still seeing very acceptable sensitivity levels, even all the way up to a pool size of 24. And so it will really depend on the population that you're looking at, but we'd be happy to have one of our PhDs go through impact of sensitivity if you were interested in going into pooling or looking at what that might do. So hopefully I answered a couple of those questions. What about direct PCR techniques? So I have not seen anyone doing a extractionless pooled surveillance or screening model. Every model I've seen out there has gone through extraction. I know we have our own extractionless PCR system that we use for diagnostic, but we would recommend doing a extraction if you're going to be doing pooling for screening or surveillance. So hopefully that answers your question, Jeffrey. Happy to get you more information on that, though, if you want to follow up. It looks like we have a question from Eric on if you pay out of pocket for a COVID PCR test, a screen or antigen, home test, or other, will insurance reimburse for your out-of-pocket expense? I think that's going to be on a case-by-case basis. I'll let Ann weigh in if she has any additional comments on that. But if it has not been billed through the laboratory to CARES Act or anything else, and you went ahead and paid cash, usually you can put in a claim, especially if there's a physician order involved. But Ann, did you have any thoughts on that?
I would agree. I mean, again, if they're paying cash, and I'm looking for the question here, John, so I apologize. I missed the very beginning of that.
Just wondering, Eric's wondering if you pay out of pocket for your COVID test, will you be able to get reimbursement from your insurer?
I would say it depends on your insurer and depends on your plan. So what we're seeing is that if this was a diagnostic test, then yes, the insurance company they are required to reimburse for COVID tests. But we are seeing some insurers where there's a particular plan that's, let's say, a high deductible catastrophic plan where they're indicating, they don't cover for COVID. What I would recommend is if you're billing and getting that denial, then the patient would need to appeal it with their insurer. On the surveillance side, again, if it's a completely different, the payer may not say that there is medical necessity surrounding surveillance testing. Therefore, they are not required to pay. So if you paid that out of pocket and submit it to the insurer and they deny it, I don't believe you have really any appeal rights there.
Thank you very much. Zvi had a question on, do we think that there's going to be more testing? So that's a tricky question. I think that on an individual level, we're probably not going to see more testing. I think we're going to see less. But if you count people that are in a surveillance or screening population, I think that we'll see large numbers there. But it's not going to equate one for one to large numbers of tests being run in the lab because of that pooling that's going to occur. So I think the jury's still out, Zvi, on how much adoption we'll see of the surveillance and screening. With the funding that's available, I think that is going to drive that adoption. Early in the pandemic, we thought pooling and surveillance screening testing at employer places and schools was going to be a little bit more prevalent than it ended up being, but there was not a clear path to getting paid for that. And now that funding is coming through the government from federal and state level, I think that's going to push that forward quite a bit. And Katie had a question about whether we're seeing payers agree that medical facilities in outbreak status would be considered potential exposure and therefore covered. I don't know that I can specifically respond to that, Katie. I can give you my opinion on it. I think that when you're in an outbreak, you can move from being in the status of just a traditional screening into more of an at-risk population because you may have had exposure. And I think that's going to categorize you more as a diagnostic sample because you may have been exposed. So if it's coming through that route and there's a physician order at some level attached to it, then I think that the payers will be required to cover that test. And I don't know if you have any other.
I would agree. And again, I keep going back to the payer is required to reimburse, but I'm sure all of you have seen where the payer is not reimbursing. So then it puts the onus on the lab to support that it was an outbreak. So that's difficult to do, but again, I say document. So if you know that it's flipped over to an outbreak diagnostic testing and you can document that somehow and appeal it with the payer, again, they are required to pay for diagnostic testing. currently under the public health emergency, that still stands. Just throwing this out there, since we have a few extra minutes, one of the things that I'm interested in exploring further is, I've noticed that there are several states that have now lifted their PHE, their public health emergency. So wondering how that will fit into, again, the national public health emergency and these national the national mandates, such as the Family First Coronavirus Act and the CARES Act, and how that, again, we know that the payers, again, they are required to pay, but they're going to push back with various policies that they feel that they shouldn't pay. So it then will put the onus on the laboratory to support and be able to appeal if they feel it should be reimbursed, because it flips over to diagnostic.
Perfect. Mary had a statement more about Saliva Direct. Yeah, very familiar. We work very closely with Saliva Direct. It's certainly used in many places. I have not seen it used in large-scale pooling surveillance testing applications, but you could be right, Mary, if that was your statement. But they're definitely doing a lot of good work there, and we really like the group over there at Yale, Ann and her team. Bob wanted to know which COVID testing platforms Lighthouse uses for diagnostic and surveillance testing. Our preferred platform, Bob, is the Thermo Fisher Quant Studios. We like the fact that they're open systems. We like that we can validate them custom based on the client's needs. And then I also like the long-term ability to pivot post-COVID into whether it's infectious disease, the respiratory, UTI, women's health, STI, PGX, all of those panels can be done on those instruments, and I think it's nice to have that versatility. We also are able to get the cost per test down quite a bit below what labs that are using like a Hologic Panther or a closed system are paying, and so we recommend the Quant Studios for that, and we would use the same Quant Studio for a diagnostic test as for a surveillance test, so we can validate surveillance testing onto that platform, and that's another reason that we are in favor of that, and we have really good pricing. If you ever needed one of those, we have preferred pricing with Thermo and a guaranteed supply on that with quick turnaround. So let us know if we can help. And then Sarita had one more question on saliva samples, how many can be tested in a pool. Don't hold me to this, but I had asked this question before. I don't know if I asked it exactly the same way to Dr. Harris, who crafted our pooling validations, but I believe it's 24 is the answer on that. It would be determined a little bit by the level of positivity, right? So as positivity rates increase, your sample pool size needs to decrease. But if you're dealing with a asymptomatic population, we're seeing really low positivity rates there, below 1%, and so I think you can get up to about 24. So it looks like that is all the questions. Let us know if we can help with anything. Otherwise, thank you guys all for attending. We will be sending more information on our next webinar. I believe our next one is going to be on credentialing, getting in-network status with the commercial payers. Always an elusive thing. We do feel like we've got a really good solution that's been working. We've been able to get labs contracts with Blue Cross, United, Aetna very effectively as of late. And we've been doing this for about 18 years now that I've been doing this, and I have not found that solution previously, but over the last 6 months, we've got a really good solution for that. We're going to be presenting that to all of you and giving you a little bit of advice, even if you want to do that on your own, regarding the strategy on how to position yourself to the payers in order to get that in-network status. So stay tuned for that, more information to follow. And thank you all for attending, and I'll give you back the rest of your lunch hour. Thanks, everybody. Thanks, Ann.
Thank you. Yep. Thank you. Bye-bye.